All right. So we've got our patient. We'll say they have T3N1 disease based on preoperative staging. No intraperitoneal mets. We were super thorough. Got a diagnostic laparoscopy. D-FLOT. All right. We give her cycle 1. It doesn't go great. She just has bad cytopenias, bad nausea, vomiting. And she's like, I don't care. I want something less intense. What's the first thing you do? This is for our, we're getting into practical things
I
now.
know. That's what's so hard, isn't it?
Because it's 4 cycles ideally, right?
Correct.
Every 3 weeks, kind of a rough 3 months go there. But
yeah, it's the Durva's given monthly.
We all
and
know
the FLOT's given every 2 weeks.
Not all of our patients are the fit population that was able to get on Matterhorn, right?
Concur.
On ESOPEC. So how do we adapt this to our people throughout the country?
Big sigh. Well, I have an answer, but of course I want to qualify it before I give it to you. Maybe I just like to make you listen to me talk, but it's the clinical dilemma of trying to predict what's going to happen based on variables you can't know. So you can make a list, or we all can, of performance status, organ function, performance status plus a multivariate equation of all these other things, and we can plug it in, and it says this patient has an 80% chance of tolerating D-FLOT. But even that would only give you an 80%. So you have, I think you have 3 options if the patient wasn't able to handle the first FLOT. You could delay and reduce doses, but those are 3 drugs. You have to pick which one of them or those.
Who do we pick first?
Exactly. who gets the first tap out? Or you could drop a drug, or you could stop. I wouldn't stop and go straight to surgery. You can obviously adjust things, but it's balancing curative intent versus 2 things: quality of life, but ability to get dose intensity. You have an out, though, and the out is not to default to chemo-RT. The out, in my practice, and I'll actually put it out there online, is you can change to FOLFOX-based preoperative therapy, and you can get immunotherapy with that because you've kind of already got it from the D-FLOT approval.
I would say that's what most the physicians in our group are doing too. If it's someone that you're more worried about, or who's just not tolerating things, the docetaxel is the first thing to go.
Agreed.
Probably because we're just simplistic, right? And we just love to give FOLFOX.
Well,
GI medical oncologist. It's just
isn't that the answer for GI? Unless it's for tubular GI, the answer is always FOLFOX, right? So helps me out a lot.
Yeah. And I would say then you're getting into fairly rare territory of patients who can't then finish out the FOLFOX durvalumab.
Yeah.
There are still a few unfit patients. I've had one in my clinic that comes to mind in particular who was just really not a chemo candidate, period.
Understood.
But she wanted curative intent treatment. And we did definitive chemoradiation, no surgery.
Agreed.
And she's sitting here a year out with an esophageal adenocarcinoma, no recurrence.
Well, it happens. I mean, first of all, I'm not sure everybody will agree with me in the current setting, especially in immunologic unstable tumors, but you have to have surgery. I'll just put it out there to cure esophageal gastric cancer. So that's the one thing I would not leave out if I didn't have to. But historically, I used to split the benefit of chemo-RT between adenos and squames. Because in squamous cells, which we're not talking about, but there are studies, one in particular whose name I can't remember, but it was a definitive chemo-RT versus RT alone for squames. And the cure rate was 25% in the 5-year follow-up. So you can definitely cure. And that's one standard of care for squames. It's RT.
For sure.
But I would always teach people that you can't cure, never say never, right? You can't cure adenocarcinoma without surgery, but you can. You just told me, but also there's a study called RTOG 1010, I think, that came out of the University of Maryland. I don't know how they got away with this, honestly, but the control arm, or it was basically looking at HER2 positive disease, chemo-RT plus or minus Herceptin, but the control arm was chemo RT, and it had some adenos.
Mm.
And there were some cures there, 10% maybe.
Yeah.
So
Yeah.
it does exist.
Yeah. I know it's a good point to make, because having your stomach removed is not a great fun operation, and more importantly, functionally, your life is forever altered after that, right?
Certainly is. Yeah.
So any strategy we can eventually maybe think of to do that would be nice.
Yeah.